Hey, Christine, are you trying to say something? I think you're on mute.
What about now?
Yes, we can hear you.
Okay, very good. Okay, so these are not working. Okay, well, good morning. There's always fun technology issues. I switched my earphones this morning. As you could tell, my ears are a little bigger. I figured that I would bring some of the Halloween festivities to our conversation this morning. So yes, good morning. So as a reminder, the topic this morning relates to QMED 2.0.
I talked to her earlier.
Could you please mute? Make sure we
Yeah.
mute ourselves. I think there's somebody who is unmuted. Please
Yeah.
mute yourself. Maybe the Alvin or May, if you could please just make sure if there's anybody in chat who is not muted, please mute them. Okay,
Yeah,
well,
sure.
good morning. Thank you. Okay, so apologies for that.
Yeah.
So again, this morning's discussion is on QMED 2.0, the webinar questions that came in from our attendees for the September webinar question. So just as a reminder, I know that we probably have quite a few different healthcare delivery systems, probably some counties. I think I might have seen Shasta County pop up as an attendee. Just so you know, today's discussion will be specific to our medical managed care plans. And so therefore, it's not necessarily pertinent or pertains to, fee for service, county behavioral health plans. So this is specific to the medical managed care plans that are submitting the X12 837 encounters. Let's see. So, okay. Apologies for that. All right. So, another thing, the PACE programs, no. So thank you. I do see that pop up in chat. And again, this is specific to QMED 2.0 is going to be kind of rolled out. Right now, we're focused on the medical managed care plans. Phase 2, we're looking to incorporate dental managed care plans. And then phase 3 would be looking at incorporating the PACE organizations. We do need to connect with internal staff, ISCD, before we kind of roll that out fully to the plans to better understand their needs. So right now the focus is on the medical managed care plans. All right, so today's discussion is only an hour, so I'm going to get right to it. I will be joined by my boss's boss, also known as our data queen, Deborah Dixon. She is the data quality branch chief. So she will be presenting on the Encounter Data Improvement Project after I go through my slides here. So let's hop to it. I think I'm already behind the clock due to our technology issues. So I'm going to go ahead and see. Now it's, oh, please don't do this. I gotta give it to the thank you. Oh, Adobe. Okay, let's go back to read mode. How about full screen mode? There we go. All right, so again, our agenda, I'm going to go through the Encounter Data background, just some of the questions that came up for the September webinar. And we're a lot about leg time, submissions, correcting encounters. You know, we did change kind of the timeline from being, 60, 80 to 360 days to 60 days. So we want to kind of go through the process and material that we looked up. And then again, as I mentioned, Debbie will be presenting EDIP updates. So Another thing before we move on, for the education and outreach specific to QMED 2.0, there are monthly webinars. If you've noticed, like this month's webinar is specific to, a topic. And the topic for this month is, again, QMED 2.0. What we have here on this slide is all of the prior presentations that we have done on this topic. And, the webinars we are trying to incorporate as, long-term resources that all of the plans can access in case they have staff turnover, like DHCS, you always are going to have staff turnover. So please kind of look at this material. If you have new staff that is onboarded with you, point them to these prior webinars. They are saved on the MCDSS SharePoint site or website for you to access, so you can link to the prior YouTube videos or the presentation slides. So just a bit about reminder of the resources that are available there. All right, so I'm going to jump right into the encounter data. Just as a reminder from the questions that came in and just kind of where DHCS is coming from pertains to, why are we doing QMED 2.0? Why is it changing? And this is just kind of a recap for that. So just as a highlight, so California, there is the map. We like to call it the map. I guess this is a map of shame because California has not been doing well. Essentially over the past 3 years, from 2022 to 2024, California has not met the TMSIS OBAs. So this is kind of a consistent issue with the quality of data that DHCS has been reporting. And so there is an issue. So what kind of issue could happen is, there are reporting requirements that DHCS has to meet. And so obviously the data that DHCS is collecting is coming from our medical managed care plans. And if that data does not meet the quality that DHCS is supposed to report on, then, there are risks that arise. Another thing to point is kind of in our prior webinars in June, we did go through for QMED 2.0, what are the encountered data aspects in the contract that pertain to quality reporting. And so we've just kind of reminded here, this is a slide from our June 2025 webinar that lists the specific sections in the boilerplate, the medical managed care boilerplate contract that are specific to encounter data reporting. And just I have a little note here, DHCS, we're getting our standards from CMS. So it's really CMS that is telling us, which is telling you that these are the requirements required for reporting. For another, again, this is just from the federal obligations of what is required. If you're so interested, once these slides are available, will be about a month for the slides to be available. But there are links in the document. You can follow the links. You can read the this information here for yourself if you'd like. And then again, just to reaffirm the federal obligations and the plans, the key takeaway from this really is that, again, as I said, that California has not met the TMSIS OBAs over the past 3 years. And so part of that is a potential risk of the funding for the state for our technology, how we're processing the data that is coming in. So there is a risk to funding on that aspect. And again, this is another reminder. There's a lot of reminders here about how important the data quality is as it needs to be reported to TMSIS and CMS. For that. So to get that kind of business out of the way, I'm going to go into the questions that arose on the lag time measure. And just as a reminder, what lag time measure is, again, in the existing QMED, this is a measure in QMED report card, the current version. For QMED 2.0, again, we did change it so that we are looking at a submission lag time of within 60 days. One of the things that we really wanted to highlight is that we are looking at original accepted encounters. So there was some concern based on, how are we calculating lag time? Is it data service, data receipt, data payment? And so just to reaffirm here, the lag time is based on the data service. And then when the managed care plan submits their post-adjudicated encounter claim or record to DHCS PACES, but again, we're looking at the original and accepted encounters, what that submission date is. So just to explain, there are some other kind of questions in chat from September about, what if you have some encounters where the, longer term hospitalizations, what sort of data are you using? So we are looking at things like, encounter end date or discharge date for that. Another thing is we are looking at data payment for future QMED 2.0 updates. Again, the point of QMED and any sort of our quality measures is they're going to be living. It's kind of like an organic, measure set where, we're going to periodically be looking at updating the measures. If there's any sort of federal requirement changes that will need to be incorporated, the measures would also change then. But again, it's all part of our communication, rollout, engagement with you all as our plans. So again, another question here is regarding, again, a clear definition of 60 days in the data service and whether or not that's the same as the adjustments reversals for claims. And again, just to remind that the lag time uses the data service. The measure differentiates 837I, the institutional, and the professional. And again, are original and accepted. So we had quite a few questions. You're going to see like a variation on a theme for the questions that we did include. And okay, so again, another question here that we had.
Christine.
Yes.
I'm sorry, are you taking questions during this webinar?
We're not going to be doing live questions. I mean, if you please put your questions in the chat, that way we will be able to gather them and provide, a detailed response. If that's okay, if you could put your questions in chat, please. Thank you. All right, so again, for this question, the threshold measure, so this one is about 90%. Again, going back to the measure here, we're looking at, for this ratio here, we want to see 90%, that's the threshold, must be submitted within 60 days to pass. So that's the 90% in this question here. And so they were asking about, how does this correlate to the Medi-Cal timely filing and claim payment days timeliness? And then a question about expected to hold providers to a higher standard. So again, just, what we're looking at for QMED 2, what we are proposing is, the thresholds are aligned with the contractual requirements as well as the TMSIS reporting requirements that I went through at the beginning of this presentation and what we discussed in the June 2025 webinar. So the parts in the contract does specify, adhering to the federal Medicaid requirements, which dictates about 90% of all claims from practitioners to be paid within 30 days of the data receipt. So, and then again, Also in the contract is that plans are required to submit encounters within 6 days following the month of payment. So these are in the contract. Again, QMED 2.0, we're looking to align with TMSIS and the contract. And again, the feasibility. So questions again, like what was the analysis? What sort of analysis did DHCS do in conjunction with MNAT on, how likely is it that the managed care plans, the medical managed care plans will meet 90% within 60 days? So there was quite a bit of analysis done on looking at compliance with various thresholds, like 90%, 80%, as well as the time periods, within 30 days, 60 days, 90 days. So yes, what we also changed for this measure is we're only looking at original and accepted encounters. The current QMED measure includes everything, which is replacements and voids. So, some of the other concerns that came up were around, if DHCS requests us or the plans to resubmit encounters, which has happened. I know that there are plans right now who are having to resubmit encounters from like 10 years ago. And of course, that would potentially have an impact on the QMED measure. So we do hear you. And this measure is looking at original and accepted encounters only. As I kind of mentioned, we looked at, there was a lot of iterative measure development. Again, we were looking at plan performance under the current QMED measure. And then also, just adhering to the contract as well, looking at the 90% number of claims that need to be paid within 30 days. And then, we do believe that the 90% threshold does provide plans sometime to communicate issues with the providers. And ideally, as part of what the contract does stipulate as well, is that the managed care plans should be vetting the encounter claims that they get from the providers prior to submitting them to PACES. So that's kind of been our expectation, is that, if you do have any issues with the providers, those should be caught up front before they're sent to DHCS PACES production. And again, you see, there's a lot of questions about the feasibility of the submission lifetime. And again, it's, did we reach out to managed care plans? And again, 90% within 60 days is a lot different than 80% within 180 days. And what they're referring to is the current QMED measure, which again looks at a period of time up to a year. And so, we are going to be providing a period of public comment on QMED 2.0. It's still going through the last stage of internal review at DHCS. So we're going to be, once that is completed, we're going to have the public comment period on the APL, as well as the detailed methodology document that lists out the measures, what the thresholds are. So, we look forward to hearing feedback from that. And again, being the data quality unit, data quality branch, there's a lot of empirical analysis that was done on the plan performance. And, the point of the QMED 2.0 is really to help drive data quality improvements so that California can finally pass the TMSIS OBAs. And again, we just really want to meet those federal reporting requirements. So we don't want to run the risk of losing any of that funding that was mentioned in the first section of this presentation. Okay, so just to reaffirm the impact of resubmission of encounter data. So again, this was a concern about the resubmissions of encounter data. And so as I had mentioned, that for QMED 2.0, we are only going to be looking at original and accepted encounter submissions. So resubmissions are not considered for this timeliness measures. And the third bullet point here is one I will very much highlight, please, as that if you're submitting encounters that are denied and denied by DHCS PACES, and some of those errors that are arising are due to provider issues, then that does suggest that maybe the plans, the managed care plans need to work on vetting the provider claims. So we really are expecting that, based on the contract as well, that there are systems that the managed care plans have to vet and validate the provider claims that they're receiving prior to sending those to DHCS PACES. So from our point of view is that if there are issues and the encounters do get denied by DHCS PACES and a managed care plan says, oh, well, it's our provider, then our reaction would be, well, then the QMED 2.0 score is accurate in that it's reflecting the poor timeliness of data as well as the poor quality of that data. So the next section that we have is the denied encounter turnaround time measure. So again, variations on a theme, the theme being timeliness of the data quality, and corrections around the submitted data, encounter data. All right, so again, this measure is specific to contractual requirements. We have the little quote from the contract here, which stipulates that corrected encounter data is resubmitted within 15 calendar days of the date DHCS PACES is notifying that, the counter was denied. And what we mean by that is, there's the encounter validation response file that lists out if the file was accepted, and then if there were any encounters that were denied. So obviously, if their encounters are denied from the contract, it says, 15 calendar days to make those corrections and resubmit to DHCS PACES. And again, these measures are broken out by transaction type. So again, there is a measure for professional and a separate measure for institutional. All right, so what do we mean by correctable? Again, the definition of correctable, this is also in the methodology report that will be available during public comment. So what we're saying is we are excluding the encounters that denied replacement encounters, denied void encounters, and encounters denied for invalid frequency type. And if you would like more detailed on that, please refer to the PACES error addendum that is in the DHCS Documentation Center. That does have a section in one of the appendices that goes into detail about the issues with these types of encounters and why they cannot be corrected. So again, we are not going to be including these types of encounters because obviously they can't be corrected. So they shouldn't be part of the calculation, and they are not. For duplicate rejections, are duplicate rejections considered correctable and included in calculations? So yes, duplicates are considered correctable and are not one of the categories excluded. That means that any duplicates that are denied should be addressed within 15 calendar days. If any of you have further questions on duplicate encounters, the reporting unit did a wonderful webinar presentation on this exact topic a few months ago. Can't remember if it was February or June, but that is available on the webinar, the data quality webinar site. So the video is available to view and the presentation available to download and view as well. So please, please, please we make these videos to help your all staff, you know, get some help. So please use these resources for these types of questions. All right, so we did have a question again on information versus threshold measures. So for current QMED, there are some informational measures as well as threshold measures. Part of the purpose of QMED 2.0 and the goal was to reduce the complexity. The current QMED measure is quite complex in how they're aggregating the measures based on whether or not it's a timeliness or a completeness measure. So part of QMED 2.0, we really wanted to simplify the calculations, make it much more explicit, and have it tie better to TMSIS as well as the contract as well. So for QMED 2.0, everything is going to be a threshold measure. There will be no informational measures. So yes, everything that will be in the report is a threshold. So for this question here, they're asking about the encounter denial rate is under 5%. Do we still have to correct our denied encounters in a timely manner? And the answer is yes. Just because you are below 5%, ideally we want them to be 0. So even though the current threshold right now is 5%, for QMED 2.0, we do, you know, we have goals that do need to align with TMSIS. And if, you know, the TMSIS threshold is really, you know, 100% have to be correct. You know, for our thresholds that we do set, we understand that, you know, there could be a lot of plans that don't pass, but we do expect the data quality to be improved over time. And again, this is a contract requirement when we're talking about the correctable denied encounters. So that's why this one is, you know, we're really aligning to the contract, and that, you know, it's really 100%. All denied encounters should be correct within 15 days. So to answer this question, being below 5% denial rate does not bypass the contract requirements. So that's that. So again, denied encounter resources. So we did have a question. Do we have a document to define the exact error logic for claim and service line level for all error IDs from DHCS? Yes, we do. Jeff Jennings, who is amazing for the data exchange, he helped the reporting unit do a whole walkthrough of the DHCS Documentation Center, and you can go find that recorded webinar. So please, there are a lot of technical documents, the companion guides, the schemas. You know, what I've highlighted here is the encounter database's validation response file description, very detailed on the file layouts and expectations. So please use these resources that we have. And yes, I did clarify the types of encounters that are correctable. Please go to the documentation center. This was also explained in, I think, last month's webinar as well. So please, again, go to the documentation center, download the documents, companion guides. I've highlighted here, response file guides and examples. In the PACES, guides and documentations for the 274 and 837 being the X12 encounter claims. All right, so available documentation, where is it located? All right, so these links here, the encounter data quality improvement efforts, part 1, 2, and 3, those are on the data quality webinar site. So if you'd like to remind yourself, if you have new staff, please refer them to these webinars and the presentations. And again, like the documentation center walkthrough is there. We even have presentations on encounter data validation testing. That is a recorded webinar. So we really have tried to create these more focused webinars based on the topics and questions that come into our data quality reporting unit mailbox. So please use these resources. If you do want to have other specific topics, please put that in chat. Unfortunately, with the elf ears, I can't read the minds. So it would help a lot to get that feedback as well. Detailed type of questions that you have, and other webinar topics you would like to discuss. We'd love to hear from you. Okay, so again, I think this is a great question that came in, and it relates to, well, if we're rolling out QMED 2.0 and there aren't any plans that pass, is there kind of a bigger issue, and what the consequences would be? So based on what we have looked at, there are some QMED 2.0 measures where all plans will fail. And I can say that these are measures that are contract related. So when we are rolling out QMED 2.0, we want to ensure that before we even do any sort of compliance, that plans have a runway of time where they're getting their report cards, the new QMED 2.0 report cards, they're looking at them, and they have a runway of quarters to start improving or bringing the encounter data quality standards into compliance before we really start doing things like warning letters, corrective action plan requests or caps, and then hopefully not sanctions. But again, we are aligning with what we're required to do, and by we DHCS. I think one thing I did want to highlight, so that I don't, I know our division chief related to some of the TMSIS measures. So I want to highlight that real quickly. I didn't want to bore you. There's like 10,000 TMSIS changes in version 4. So when my boss's boss said, hey, let's mention that, I said, well, okay, let's not talk about all 10,000. I want to just mention the specific ones that relate to QMED 2.0, and there are some of the financial. So there are about 10 updates to financial transactions that TMSIS has made in their version 4. And so some of those, anytime, like I said, TMSIS does make a change, DHCS needs to be in compliance with that. So if we need to be compliant, we have to pass that on to you so that we're all in compliance. So some of those that I do want to, of those 10 TMSIS updates to the financial transactions that will impact encounters, and again, encounters, to be incorporated in QMED 2.0. So some of the things that TMSIS has updated or expanded are things like individual capitation payments and sub-cap payments, cost-sharing offsets. So, if you are interested, these are all available to be downloaded at medicaid.gov/TMSIS. And again, so there's 10 financial transactions. Again, things around payment data. Payment data, very important for QMED 2.0. We're looking to incorporate payment data to align with these new TMSIS measures. So again, for some of the lag time measures, while right now we're looking at date of service, we are looking at, date of payment as well. So again, we understand this is going to be, organic, living document as in, the measures, we expect them to change over time, depending on, TMSIS changes or new contracts that come out, if there's any sort of new data elements that we need to report on. So again, medicaid.gov/TMSIS. And yes, I think with that, I'm going to hand it, well, not hand it off. I will get Debbie's slides up for her, and let's get her on. All right, so good morning, Debbie.
Good morning. Can you hear me?
Yes, I can.
Great. Okay, next slide. Okay, so my name is Debbie Dixon. I am the Chief of the Data Quality Branch here in the Health Information Management Division, as Christine has mentioned. So I'm going to give you an update on our Encounter Data Improvement Program. We've been conducting these webinars the last Wednesday of each month for the last couple of years, and we're bringing forward. The intent here is to provide a variety of topics, as you know: submission requirements, issue resolution, implementation updates, concerns that you may have. These webinars are recorded and the PowerPoints are available in the Documentation Center, as we've mentioned a few times, so they can be accessed and shared with your staff. So the intent here is to provide a resource for you to help with those issues that you may have on this with your staff. No one understands staff turnover like we do, so we understand how that can be. So this hopefully is a tool that you can use for your staff onboarding training. That's a part of what we're trying to do here. QMED, we've talked a little bit about that today, and I'll give you a little information on what we're going to do with that here in just a minute. And a Managed Care Hub website, another resource for the plans, and mention that it's also a public facing site. Next slide, please. So here again is our map that CMS has on their SharePoint, on their website. So blue is the standard. That means everybody is meeting the requirements. Yellow means there's some work to do still. And red, you're in danger of losing your federal funding. So when we take a look at that, we all know the data flows from the providers to the plans to DHCS, and then we submit that to CMS. So what you see here is the screenshot that's public facing. Anybody can look at this, that shows the data quality issues that all states what the status is. And this is an aggregation of all of the data quality issues at the federal level. Like I said, we are in yellow, so we've got some work to do fixing our data quality. So just like we did during the pandemic, CMS relaxed some of the requirements, especially around compliance actions, and now they have brought that back to the front again. So CMS released a state health official letter in May of this year, reaffirming what their expectations are for the quality of Medicaid and CHIP data through the TMSIS files that the states send to them. In addition, they've resumed the compliance actions starting September 1st, 2025. So now, states' failure to submit high-quality TMSIS data means we're putting our federal funding at risk, which could also impact states' managed care contracts if the encounter data is not properly collected and reported to CMS. So this is an all-of-us issue. Provider to the plan to DHCS to CMS. So CMS can cut our funding for specific type of patients or services that are affected by the problems because that funding is specific to different systems. We have the fee-for-service system, the managed care PACES encounter system, a system for behavioral health, etc. So wherever the issue is that's making the system non-compliant, they would be at risk of losing funding for those particular programs. That's why we mentioned it can specifically be for certain types of patients or services, depending on which system is out of compliance. So clearly, data quality is a high priority for all of us together. Okay, next slide. So in the spirit of that transparency, and here's a screenshot of a hub that we've created as part of our Encounter Data Improvement program that is meant to provide access for different types of issues, as you can see here, that plans may need. We would also provide the what you see listed here, frequently asked questions, news and events, if there's delays in the file queues on the PACES system, upcoming webinars, what we've mentioned before, of course, our documentation center, and also the data quality reports. The QMED 2.0 and the Encounter Data monthly reports will be housed on this site. This will be public facing, so it's available for folks to take a look at on the state level to align with the transparency requirements that the feds have told us are necessary to meet compliance and accuracy requirements. So there's a federal requirement for the states and the plans to maintain specific content on a public website that's accessible to enrollees, which includes plan for performance and quality ratings. So those requirements are in the Federal Register that governs the Medicaid managed care program. The most recent update in the managed care final rule emphasizes transparency, accountability, and health equity in Medicaid managed care programs. So to that end, we are creating this website, one-stop shop, if you will, that's also public facing, that will include the QMED reports and the monthly data quality reports. Next slide. So here's a sample. In a future webinar, we'll do a deeper dive, but I just wanted to give you a heads up that this is a part of our improvement program, and what we're doing as a whole, all of these different pieces and parts are here to make things easier for you to work with providers and figure out what the data quality issues are, and we can help each other to provide the accurate data quality going to our federal partners. So the data quality reports will be available. There's a summary, and you can see by county, and you can compare them. What you see here is fake data. So this is something just for illustrative purposes, but you can see by the performance measure itself, you can see the measure details, which plan, which county, a lot of really good detail that you can hone in on where the quality issues are and where we need to fix county by county, if that's what you want to look at. But we will be doing a deeper dive. Like I said, either November or December, one of our upcoming webinars will do a deeper dive on the website itself, so you get an idea of how that works and what all's available out there. All right, at that point, that's it for me, but I'll turn it back over for the rest of the presentation.
So that is, thank you very much, Debbie. And so for the next month's webinar, will be on the plan data feed. So if you have any questions or comments pertaining to the webinar series, please email mcds@dhcs.ca.gov. Again, that's specific to the webinar. And then I will just go back, you know, as far as kind of the other encounter data quality improvement efforts. If you go to the data quality webinar, and again, you can email the email that I just showed, mcdss@dhcs.ca.gov. Go on that website there. Please review the prior webinar materials and discussions that pertain to QMED 2.0 to, you know, review anything that we've discussed before. And then if you have any other additional questions regarding QMED 2.0, please put them in chat. And yes, so, all right. I'm going to stop sharing here. Okay, so I think at this time, you know, if you have any questions, I think someone mentioned that there is a hand up. Yes.
Hi, yeah, it's me again. I'm sorry. I'm sure you covered this, and I'm just not as much of an expert as all of you. So can you just talk me through the tension I'm hearing between the fact that I think providers have 90 days to submit a claim, right? So even if it was clean and not resubmitted, does that interfere with your metric for plans to then get you that encounter within, is it 60 or 30, right? Can you talk me through that tension?
I'm not sure I understand the tension, and this is something we might have to, if you put in chat with some more details, because again, when we're looking at the contract, the managed care contract, now QMED 2.0, we're looking at 60 days. So the lag time measure that DHCS is looking at is within 60 days from the date of service. So that's essentially 2 months for when, a provider sees a member, the provider submits the encounter claim to the managed care plan. And say if that's 30 days, then the managed care plan essentially has another 30 days to submit it to DHCS PACES.
Okay, I got an assist from Norm. Okay, so hearing that, Christine, and knowing that providers have 180 days to get that information to the plan, I feel like I'm missing something.
I think we'll have to take this. If you could please you can email mcdss@dhcs.ca.gov with more details on 180 days and more specifics on the questions. I want to make sure that I fully understand the question and that we can provide an accurate response. Because it is, I want to make sure that we do understand your question,
Sure.
the details around it, and then we will provide, better response.
Okay.
It's always
I think that's a lot of what you were seeing, right? So like in the chat, but we can resubmit or submit it differently because I know you answered some questions you saw, but in a nutshell, providers have longer to submit the encounter to plans if we're using date of service, right? They have 180 days. So I think any metric that is more aggressive than that doesn't allow the provider even time to get that encounter to the plan.
Yeah, I think we'll have to understand, and again, just from the side of however the contracts are with the providers to the managed care plans, that's not something that DHCS is privy to. So again, if there is something different and specific about 180 days from your question, please put it in an email. And again, also during the public comment period, obviously there will be a big notification when that happens.
Totally. I think the value of this time, right, which I really do appreciate you guys taking the time, is for us to understand before it gets to public comment, right? Because I totally understand your guys' goal. Makes complete sense. We do not want to put federal funding at risk, right? Mm-hmm. So I hear you. I just think if we could do some work before it gets to that point, it'd be super helpful, because we don't want to set the whole us, anyone up to fail. And if providers by statute, have longer, or by Medi-Cal's rules, these are not the plan rules, I think we need to allow them sufficient time. The second thing I'll say before you cut me off, because I'm hearing that you don't want to discuss this now, and so thank you, is that I have genuinely received a lot of feedback that is just saying like that the process of correcting these claims with the providers just takes longer than what you guys are proposing, right? And so what we want to do is work with providers and get claims clean. Now, if the goal is to clean up encounters, I think we can work with you to get there, right? But what we want to make sure we're doing is allowing enough time for providers to clean up that data, which they're not incentivized to get back to us timely, right? So we can work on how to do that, but I don't know that this is going to achieve the goal. So just a request that if we could have some more conversations, I think that would really help, because we share your goal of not wanting to put any federal funding at risk. So I guess that's the bottom line. So thank you.
No, I appreciate that. And again, like I said, please provide details. Please send an email about your specific concerns. That will really help us be able to research and provide detailed answers. And again, we really appreciate the collaboration. We appreciate the feedback. So thank you very much for raising this question. I look forward to your email with those details so that we can get on it and provide some clarification going forward. So thank you very much for bringing this up.
Yeah, appreciate that.
This is Debbie. Just to echo what Christine is saying, that's the whole point of this. I mean, all of this to say, we're all in this boat together. All of
Yes.
us are under an edict to align with federal requirements in order to keep our funding. We've got to meet certain thresholds and measures and data quality requirements and such, right? So the point of this, the whole idea is for us to work in collaboration and for you to give us the kind of feedback we need to help you. So we need to know, to your point, if there is some restrictions, just we're looking for that kind of feedback. We're trying to hear from folks on what it is that legitimately is making it difficult to meet certain requirements, so we can take that kind of thing into consideration. So we do appreciate you bringing this up. We do appreciate any questions or concern, and that's the kind of feedback we're looking for.
Thanks, Debbie. Yeah, I guess I would just offer in that spirit, totally understand why the organization here makes sense and allows you guys to give like comprehensive answers. But if we could combine that with some question answer like we're doing now, I think that's helpful, right? Because then we can kind of dig into where there's still understandings, and people who know much more than me who are in the chat, right, can speak up and help give you guys some of that feedback or some of that context that I don't know, but they live and breathe every day. And so that we can get to that joint understanding. That would be my request, but I'm very appreciative of the time and you guys answering our questions. So thanks.
And it's very, very helpful for you also. And I see some of that in the chat. So that really helps us to do some deep diving on where these folks are getting the thought of where the requirements are. So it's helpful for them to reference. We're looking at this manual, or give us a link or whatever, so we can clarify what belongs. Some of this may be fee for service, for example. So we need to know where they're looking in what documentation and where they're quoting, so we can come back and determine whether or not that applies to managed care plans. Is that a contractual requirement, or where do we need to look? It is kind of the short answer. That's very helpful for us to know what they're referring to when we go to respond to that. So that's helpful. Thank you very much.
Thanks.
All right. Well, as I said, please, if there's any questions, I know this is quite a complicated product, so it's Debbie's project and topic. So please, as Debbie mentioned, it is very, very helpful when we do get questions. Please be as descriptive and explicit as possible, especially when we're talking about the X12 transactions. If you tell us like the header, the loop ID, this is all extremely helpful for us to understand what you're looking at so that we can look at it and have a shared understanding, because it is a very technical topic when we're looking at the X12 transactions. And the implementation guide, that's like almost 700 pages, so a lot of stuff. Again, any emails, any questions, please mcdss@dhcs.ca.gov. And I guess, thank you all very much for attending, and we will catch up next month. So happy Halloween. Goodbye.